first case would be presented by Dr. Ashish Nagpal. I would request that it's a quick case discussion, so try to finish your presentation faster so that we can have good discussion. Thank you.
Okay. A very good evening, everybody, and I think I'd like to take this opportunity to thank Narayana Nethralaya, Dr. Rohit, for this wonderful conference and discussions. And I'll quickly go ahead. I think from all the discussion about the deciding the ectasia, the PTA, I'll come back to a very basic clinical discussion, a case. So this was a young gentleman who had come for LASIK, but on the day of LASIK he came with the red eye, like this. Eventually we diagnosed him as a case of adenoviral conjunctivitis, and he developed a very severe form of adenoviral conjunctivitis with membranes. So we had to start him, along with lubricants, we did start him on some topical steroids to relieve his symptoms. So after the course of a month, he got relieved of the primary disease, but he started developing these subepithelial infiltrates. And as we know, with the subepithelial infiltrates, they keep waxing and waning over a period of a long time. So I'll just cut the story short. So this is almost after a year. So this is what he looks like after having various symptoms of coming and going of the visual debility. So this is what his left eye and right eye look like. They are more or less scars. Just to highlight, sorry. So on the left over here, as we have, so there's no activity. This is how an active lesion looks like. So there's no activity now. So this is the case. Basically, the topography is normal. The corneal thickness is normal. He needs some refractive surgery. So I wanted to give in this case that how should we go ahead and handle it. His dry eye is controlled by using QID anti-lubricant eye drops.
Are you giving him any topical steroids?
Not since the last 3 months he's been off. He's had no symptoms. He was using it once a day or once in a week earlier when he had those symptoms, but since last 3 months he's been totally off it, only topical lubricants.
What's his corrected vision?
Sorry?
What's his corrected vision?
Best corrected vision?
Right. In other words, are these affecting his vision?
Yes. So his vision, the Snellen's, the high contrast vision is 6 parts. But he has symptoms of glare at night while driving.
Okay, so I think same thing. If someone's vision is reduced or if they have symptomatic complaints of significant glare, I would also start them on the lowest dose possible steroids. I would just take exception to the statement you said he needs refractive surgery. He doesn't need refractive surgery.
I think the main thing is to try to clear the cornea.
Exactly.
I had a patient like this.
Can
you
last
hear
years.
me?
Yeah, I can't hear you.
Are you able to hear me?
That's why I'm coming from.
Okay, so I had a patient, in fact I have several patients like this with basically a post-adenoviral nummular keratitis that's persistent and sometimes topical steroid dependent. And some of these cases do not respond to mild topical steroids. You need to give them like prednisolone 1% before it actually clears. So I think what you need to do is, although sometimes I think they can be quite asymptomatic when it's inactive, but like in the picture you showed just now, there's a lot of fuzziness around the lesion, so they're active. And I would give him a topical steroid and start with the lowest dose possible, but if it doesn't clear, you probably need to step it up. And what I've found is that topical cyclosporin, 0.5%, 4 times a day, is quite useful in such cases. What I do is, in times when they are very active and symptomatic with photophobia, etc., I will give them topical steroid. In fact, some of them actually need Pred Forte, right? And once the lesions become inactive, I will continue with the topical cyclosporin for 3 months or so. And with time, the last few patients that I've seen actually cleared pretty well. Okay, but sometimes they recur.
Yeah, so I've had a case last 3 years before it cleared. But the thing is, so, you don't want to, the ablation rate may vary, and these are significant in the one eye. So I would not really want to consider refractive surgery on this patient of any technique until at least they substantially cleared, at least in the visual axis.
True. So what if at some point they get completely scarred off? Then what, could we do something else for them?
Yeah, what I've done in those cases when it's very stable is consider PRK or PTK, but that's tricky because the vision may be distorted by many things, the refraction, the irregular astigmatism, and the light scatter. So to distinguish between those, you can, for example, do OCAS measurement with a hard contact lens because it neutralizes the irregular astigmatism somehow, and you are left with the scatter of the opacities. And that's a nice way to quantify the effect, separate the effect of the opacities and from the irregular astigmatism. And when it's time to correct, sometimes maybe transepithelial PRK or PTK, or call it whatever you need. For example, here in a myopic patient, I would probably do transepithelial PTK because I would just remove some stromal. I would go through the epithelium. When I reach the stroma, I would notice the depths I've reached, put it to 0 again, and now start this stromal ablation and stop maybe, in this case, I would say about like maybe 50 micron. And then I'm sure it's going to remove some myopia, but I cannot tell the patient how much. The thing is, if you remove the epithelium and do like a Manolin profile, you may expose the Bowman's membrane very irregular to the laser and reveal some irregularity which was compensated by the epithelium.
Right, I agree with them. I just wanted to point out that in these cases, essentially, if you treat them with higher steroids initially, like the more potent steroids, you can actually prevent this from happening. I would say prevention is more important in this. Because most of the cases, if you treat them with the higher dosage of steroids initially with cyclosporin, as Scott said, you may not land up with something like this. Because if this patient has been on follow-up for a year, I think maybe that would have been a proper line of management, maybe to step up the steroids and add cyclosporin at the right time. And probably this could have been prevented. And now having a picture like this, of course, I would agree with what they're saying.
True. And that's something that as ophthalmologists we are exposed to get because we are in contact with those patients. And I had 2 colleagues who got this thing, and I did this strategy on both of them, wait them to be very stable, healed, and then do transepithelial PTK, and it worked quite well. And one has become professor last year even in France, despite this cornea. So he's happy, and I'm happy too.
So would you wait for, like,
Yeah,
how long would you wait?
I would disagree right from the start with your management of this patient, because in an adenovirus, even with the membranes, I would peel the membranes, but I would started with cyclosporin 2% drops, which we have in India, and the tacrolimus ointment at night. The moment I saw any corneal involvement, it would have been only tacrolimus and cyclosporin and lots of lubricants. No steroids indicated right from the beginning. Once you start steroids, it's a vicious cycle. It just keeps going downhill. You taper it off, then some people will say I had higher dose of steroid. Some people will say put the lowest dose. The idea is no steroid would have helped. I think in 6 months' time you would have got to this scarring formation instead of waiting 1.5 years. I wouldn't do any refractive surgery. That's a different question, but I wouldn't have had this lingering for 1.5 years. I would be strictly no steroids in adenoviral corneal involvement.
So
Okay,
at that point, sir, can I take a question with Dr. Muscati? At what point would you operate then? How long would you wait?
I wouldn't. It's as Dr. Bellin said. It's not that every patient you have to operate.
surgery.
I mean, yeah.
But the idea was that if he's very keen on surgery, what should we do?
There are
Dr.
lots
Ram?
of patients who are very keen on surgery to whom I've said no for many, many reasons. I mean, the corneal thickness may not be enough, and so many reasons. I mean, all of us, Ramamurthy today talked about saying no.
So are we concluding that we would not operate at all in such a case?
I would not until and unless there was zero glare from this patient at some point.
I would beg to differ in the sense that obviously the central optical axis, there are opacities, we're not going to go ahead. But as was suggested, once the opacity subside, the signs of activity, the haze around that subsides. And if the patient is having best corrected visual acuity of 6/6 and there's no loss in contrast, you can still go ahead and operate. And maybe this is multiple opacities like this. One of the situations I might prefer a microkeratome flap over a femtosecond laser flap because there might be areas of addition which may not come off. Otherwise, doing a PRK would also be an option.
So in PRK, would you expect some amount of haze post-surgery?
Well, I think most of these opacities are going to be superficial, and I don't think the stroma would be involved in this, and it's going to come off once you do the ablation to remove the epithelium.